Hi, everybody. Hi, welcome. We're going to go ahead and get started. Here is the disclaimer. Thank you for coming to our session today, CF Pharmacy 101. My name is Kelly Liao. I am an advanced certified pharmacy technician from the University of Louisville Adult Center. And then my co-chair is Kyle Fisher from Keck Medicine of USC Specialty Pharmacy. We are both honored to be here today. So we're going to go ahead and get started. Our learning objectives are here if you want to look over them. And I'm going to go ahead and announce our first speaker is Lisa Prunty. She is a CF pharmacist at the University Hospital Rainbow Babies and Children's Hospital in Cleveland, Ohio. Lisa completed her residency at St. Mary's Medical Center in Huntington, West Virginia. Following residency, she worked as a clinical assistant professor at Marshall University School of Pharmacy. She moved to Rainbow in 2017, and she has developed the CF pharmacist role to incorporate both inpatient and outpatient pharmacy care for both children and adults with CF. She precepts numerous pharmacy residents from the UH system each year. Lisa is passionate about quality improvement and is the Rainbow CFLN QIL. She is also the proud recipient of the award, most likely to have 40 tabs open at once from her CF team. So welcome, Lisa.
Great. Excellent. This limits me to one tab. Awesome. Well, thanks everybody for coming today. I am thrilled to be talking to you all about the role of a pharmacist and a pharmacy technician on the CF team. To get a sense in the audience for where everybody is with this topic, like raise your hand if you're kind of a new pharmacist or pharmacy technician who is trying to figure out what this role entails. Anybody? All right. Got a couple? Is anybody on a team that doesn't currently have a pharmacist or pharmacy technician and is trying to come up with some ways to get one? Got a couple? Okay. All right. And then everybody else is just supporting pharmacy. Hooray. Pharmacy rocks. Awesome. All right. I have nothing to disclose related to this presentation. And you can see I made up some objectives too. So we're going to be talking about the role of pharmacists and pharmacy technicians, talk about different strategies for justifying these sorts of services that we can offer, and then kind of talk about what adding pharmacy to the team means to people with CF. So as you guys are probably familiar, the CF model of care was updated last year, and it's pretty timely because medication complexity has gone up and up and up over time, and high-cost therapies are getting more and more utilized. But this also results in people feeling better and doing better, and so a lot of the shift has gone from, that inpatient management out to the outpatient management. And so if we look at the updated guidelines, we can see here we've got a new set of core team members. And so you can see it's nurses, dietitians, respiratory therapists, social workers, pharmacists, mental health coordinator, and genetic counselors. And then we've also got all these folks here that are really important to the team. And for the purposes of our presentation, we've got pharmacists and pharmacy technicians. So awesome. We're being recognized. This is great. It's kind of muddy though, right? Some of these things are newer, and so a lot of teams maybe don't have a pharmacist yet, or maybe don't have a pharmacy technician yet. And so a lot of the roles, maybe even be pre-existing, overlap. So of course, we are a team. That's the whole point, right? We're the CF team. And so a lot of the roles, if you're coming in new, might be done by someone else, right? The respiratory therapists might be doing some of the medication education, or the dietitians, or the nurses. And so it's good to recognize that each of these things is not like done within a bubble, right? So some of these tasks that pharmacists typically do, like medication education, and some of these tasks that a pharmacy technician might complete, like medication access related tasks, prior authorizations, might actually be completed by other team members right now. And so as the pharmacy team, our job is to kind of like take those things from the others to give them more time to do their jobs. And then we can kind of take over when it comes to medications. And when you add pharmacy to the CF team, patients do better, which is great. And there's a whole lot of literature. A lot of you in the audience have like contributed to this body of literature. So please keep it up and keep going. If for those of you who are new, yes, please take a picture of it. I tried to reference a bunch of different articles so that you can use these things. But you can see that adding pharmacy to the team helps with medication adherence. It helps with access. It helps with different communication outcomes, improves satisfaction, and it reduces length of stay. We can also reduce the time to delivery of meds. We can reduce the number of pharmacies that each patient has to use. We all know that can get really complicated really fast when insurance requires like 3 to 5 pharmacies. Decreased time to prior authorization approval and decreased medication cost out of pocket. So all these things really are good, and they can lead to some of these improvements in clinical outcomes. And so a lot of times you'll see that people want to know, like, well, what are you doing, right? Like every number has a story, every story has a number, like we like to say in QI. And so it is good to, keep track of some of these different outcomes, especially if you're new and you're trying to determine like, okay, well, how can I justify my role here? So you can keep track of, say, the number of clinic visits or the number of educational sessions, the number of people who are at goal for some of these clinical outcomes, number of interventions, of course, the number of prescriptions, the time that you spend doing education, number of prior auths. These are just some examples if you are trying to justify. And then clinical outcomes, the things that we're typically looking at, which you'll hear a lot more when we talk about the actual med therapies. But you could use FEV1, BMI. I know for some of the integrated health system pharmacies, we have to keep track of outcomes for some of the insurers. And so we can track number of exacerbations or number of hospitalizations. But of course, that's really patient-centered care, right? Like these are the outcomes that we want. So it's also things you could track from a quality improvement standpoint as well. And so I mentioned the integrated health system pharmacy. For those of you who have access to one, it's a really great asset. Like we mentioned before, it can decrease the time to getting medications. And I have found that, I work myself in one of these types of health system pharmacies, and it really can reduce the holes in the Swiss cheese, since we can kind of own that whole process ourselves in a way. So in Ohio, we have a collaborative practice agreement ability. I know not every state has the ability to build one of these, but basically you work as more of like a mid-level where you have, you can reroute prescriptions and you can order your own labs. So like I said, every state handles these collaborative practices differently. Some places want you to be credentialed. So it's some questions that you can ask of your health system. Can I get a collaborative practice? But I feel like that really does help. Because if I do a clinic visit with someone, and let's say we're starting a medication, the prescription can be sent to the health system pharmacy after I do the education, and then our pharmacy technician will get that prescription, do the prior authorization. She can do the financial assistance, the billing, adjudication. And when we find out where the patient is able to fill, she can let me know, hey, the insurance requires some outside pharmacy. Then we can, reroute the prescription there. Or if the patient would like to fill with us, then she'll call them and we can set up the delivery. And something that I've really long advocated for when it comes to the integrated health system pharmacies, we have some control over what sort of meds are sent and where they're sent. So we can send non-specialty and specialty meds from our specialty pharmacies. So it's good questions to ask. We didn't always do this. I just kept asking and asking. That way we can reduce those number of pharmacies. Also, you can ask, can we send the neb nebulizer cups too. And I've gotten a lot of yeses. So you would be surprised. Like, so ask those questions of your integrated health system pharmacies. Can we start sending neb cups with all of, our, say, inhaled tobramycin, which you'll hear about later. And then we also, when it's at an integrated health system pharmacy, you have some control over where. So typically families want medicines mailed to their homes, but sometimes they want to mailed other places. So if someone is at discharge, we can do a meds to beds, right to the bedside. Or I even have some families that prefer meds in clinic. They have some issues with medications being delivered to homes. They're afraid things are going to get stolen. And if they come to clinic at a frequency that the insurance will allow us to fill the prescriptions, we will actually have the medicines delivered to clinic, and then I can hand them to the families and to the people with the adults with CF that we see. And we can do education actually with the drug in hand, which is oftentimes very helpful. And then, of course, the prescription volume helps when you have an integrated health system pharmacy as well as from a financials standpoint. And then, of course, we can set up our reassessments. And so we'll document the frequency of reassessing patients either via the phone or via visits, where we're documenting things like quality of life and pharmacy satisfaction, which the accrediting bodies want to know about. So, for example, many integrated health system pharmacies are accredited through organizations such as ACHC and URAC, and they want to see that kind of documentation. So if it's already in there, we've already talked to the patient about it, then you don't have to do it a second time. So I find that saves time. And so I get this question from a lot of, especially residents. I take a lot of residents and they're like, well, if we're not starting a new medicine, what do you talk about? How do you start that conversation? And so I've given some examples of things that we would potentially review at a visit. I do most of my visits in person, but you could definitely do these over the phone or via telehealth too, depending on the state that you're working in and what the rules are. Sometimes there's some rules about telehealth and whether or not you choose to bill for your services. So I don't bill for my services. So if I want to do a telehealth, it's just a matter of setting it up. They have to be in a state where I'm licensed. So just make sure that you check on that before you set up visits for people in states that you're not licensed in and then have a problem. But you can see we would go through, any of these number of things and really build relationship with these families. I think it's really important to be able to know that they can call you no matter what. Like, I feel like we get calls about, I'm like, call me about anything medicines. It could be you lost your insurance. It could be you have a question. I have some people that will reliably call me about, starting these random OTC meds. And I'm like, that's great. I'm so glad that you asked me. I'm always happy to talk to you about a drug interaction. And so to help, especially since some of you are new and just to kind of go through a visit, I included some examples of a de-identified pretend note. And so, to kind of go through what we would do, it's like a typical reassessment. This isn't every visit type, but you can kind of see the sort of things that we might go through. So we would go through what kind of medicines that they're on, if it's a maintenance med that they've already been on, is it working? Are they at goals and are they meeting their goals? Like we talked about before, like clinical goals. Are they having side effects? And then, of course, we can always use these notes to complete the prior authorizations too, which can help as well. So, and we can use them for URAC and ACHC. So, that's the first part of the note. I know they're kind of long. Medication use. So we talk about unplanned missed doses and barriers to adherence, which I think everybody is familiar with, and I think we're going to talk about more later in the presentation. And then talk about any kind of changes, allergies, medical conditions, genotype modulator dose. I know we're going to talk more about modulators later, but a lot of people are on off-label doses because of side effects, so we can't always order it that way. And so this is just a standardized place where we keep what dose they are actually taking to make sure that we keep track of that. The last 3 PFTs, pull in the labs. Our EMR does pull this data in when we put in the template, so that makes it kind of convenient. And then questions, concerns, the quality of life and the satisfaction sorts of questions, and then the risk assessment. And then if patients have any other questions, of course, we would go through them. But that's just kind of like a sample note for some of the things that, you know, hopefully it like stimulates your mind about what things you can talk about during a visit. But there's a whole bunch of other things clinically that we can do too. And I put this list of things here, and I'm not going to read them all off, but take a picture of it if these are all things that you are interested in, because I know it can be kind of overwhelming, especially when you're first starting. You might think, oh my gosh, I'm only doing a couple of these sorts of activities. But it takes time. Over time, you can build your clinical practices. So just do your best. And what I also want to point out on this slide is that notice it's not just the pharmacists, right? Like the pharmacy technicians are also participating in these activities as well. You know, so I know Julie, who you're going to hear from in a second, was participating in a quality improvement project looking at eye exams and making sure that we had eye exams for patients. So it's definitely not limited to pharmacists. Pharmacy technicians can definitely do these activities as well. So I'm going to point that out. And then, of course, there's other sorts of non-clinical activities that you can participate as a pharmacist or a pharmacy technician. Things like mentoring, EMR, health record optimization. I feel like I put in a lot of things and I liaise a lot of different sorts of orderables are not working, get a lot of questions. Of course, teaching is important, bringing people into our CF world. And then research and publication, as we already talked about, kind of advocating that we get more literature out there about how great pharmacy is. So in summary, CF pharmacists are members of the core members of the CF team now. Pharmacists and pharmacy technicians both have shown that they can improve clinical outcomes for people with CF, and there's a lot of opportunities for expanding these roles. So keep going out there and doing it, and I will leave you with that. What questions do you have?
Also, feel free to raise your hand out there. We're waiting for the online poll system too, but if you have anything, we're here to listen as well.
Mm-hmm. Yes.
You had a question about like, is the patient determined to be high risk?
Mhm.
Or do you have like preset categories that you deem as high risk?
Yes. So the question was about who is deemed high risk. And yes, there are categories that our pharmacy has standardized for who it counts as high risk. So for example, all pediatric patients are considered high risk. So anytime we're seeing a pediatric patient or a geriatric patient, because I do both peds and adults. So if they're over 65, they also would be considered high risk. There's some other things that get a little dicey, right? Like if they have like other sorts of risk factors, right? Like if they have like, say, alcoholism, don't always want to put it in the note. And I think I forgot to mention that the patients have access to these notes. So they can read all of our notes. They have access to them in their MyChart. And so, I am cautious about what I put, even if someone is maybe determined to be high risk of like, say, like non-adherence is one of the risk categories. That was the list was created by the specialty pharmacy for like an accreditation thing, but that's my most frequently selected one is pediatric. Yeah, good question. Thank you. Yes.
Is it recommendation for frequency of like how often a pharmacist should review or talk to the patients, or is it every clinic visit or?
That's a good question. Yeah, so the question was about frequency of visits and how frequently pharmacists see patients. I think some of that is determined based on, I think there are maybe some clinics out there, and you all can keep me honest, like who maybe pharmacy does see the patient every time. I know in our clinic, I'm the only pharmacist for 300 patients. I just don't have that much capacity. So So I kind of set myself some minimum standards and then like almost always exceed them, if that makes sense. So for example, if the patients are filling with our integrated health system pharmacy, one of the requirements is that they have to be reassessed within 12 calendar months minimum. Realistically, I'm usually seeing people about like every 3 to 6 months, depending on the situation. But, especially as people are getting healthier and healthier, and maybe they're only coming in for 2 in-person visits and 2 virtual visits a year. Sometimes it's more like just a quick checkup, But so from an accreditation standpoint, it would be at least once every 12 months rolling. Of course, CF Foundation recommends that pharmacists and all the key team members see everyone at least once a calendar year. But typically it's more like every 6 months in my space. And anyone else can add anything. Yeah, the liver guide, every 6 months for the liver guidelines too. So it gets a little bit more. Yeah, thank you. What else? We'll use our PEP skills.
I have a question.
Yes.
Are there any opportunities for technicians in clinic, like in person?
Yeah.
Can you talk about that?
Great. Yeah. The question is, are there opportunities for technicians in clinic? And I think the answer is yes. I think it would be great. I wish I could get my technician to come to clinic, but she really likes being virtual. But I do believe that there are clinics that have technicians, in the space. I know I've invited mine to come if she wants to come to the clinics. I think, building those relationships, like right now, the person that I just have in my clinic prefers to do phone calls, but I think that just developing those relationships for the techs to develop the relationships as well would be amazing. And I would highly encourage it. Awesome. Thank you.
All right. Thank you, Lisa, for that. So we'll introduce our next speaker now. So we have Julie Langhorst, a certified pharmacy technician and patient care coordinator from Riley's Hospital for Children's Indiana University Health. Julie has been a pharmacy technician for 20 years and has worked in all areas of the pharmacy world. She joined our pharmacy team in May of 2022 to make sure people with CF can continue to gain access to medications they need. Julie was interested in working with people with CF because she wanted to help others navigate obtaining and affording their medications. Julie has 2 adorable St. Bernards and a chocolate lab, enjoys traveling, cooking, watching sporting events, and spending time with her family. So please welcome her up.
Good morning or good afternoon, everyone. Thank you for being here. Like you said, I'm Julie Langhorst. I'm a certified pharmacy technician and patient care coordinator. And today I'll be talking about the challenges and solutions related to medication access and adherence in the cystic fibrosis community. My hope is to give you both insight to the barriers families face and practical resources that can help. I have no relationships to disclose. Who I am. I'm a patient care coordinator and pharmacy technician. That means I advocate for patients and families, helping them navigate the often complex process of getting their medications. I work directly with the CF team to resolve insurance and pharmacy issues, assist with new medication starts, making sure patients can continue treatments they need. Most importantly, I consider myself a partner to patients and caregivers, making sure they're never alone in this process. A day in the life of a CF med routine. To understand medication access, did I go backwards? Yep. Okay. Day in the life of a CF med routine. To understand medication access and adherence, it helps to recognize the sheer burden of daily treatments. In CF. People with CF spend 3 to 5 hours a day managing therapies, like taking enzymes before every meal and snack, doing airway clearance techniques, like the vest, doing inhaled medications, taking CFTR modulators, taking various vitamins and supplements, and sometimes insulins. On top of that, equipment like nebulizers need daily cleaning and sterilization. It's exhausting, and that's before adding the challenges of getting medications approved, delivered, and paid for. I like to remind families you're doing the best in a system that doesn't make it easy. How CF team members navigate medication access. Medication access often requires creative problem solving by the entire CF team. We handle prior authorizations, appeal denials, and connect patients with cost relief programs to offset high copays. Communication is key between specialty pharmacies, local pharmacies, patients, and providers. We also help families explore financial assistance and keep close eye on billing to make sure claims are filed correctly and in the right order. This behind-the-scenes work is critical so patients can focus on their health instead of the paperwork. Some manufacturer programs that are available. Several manufacturers offer patient support programs. For example, Vertex provides copay assistance and patient assistance for their modulators. Enzyme therapies like Zimpep, Pertzy, and Creon have copay support and patient assistance programs. Pertzy has a First Start program that allows a one-time free 30-day supply while the care team works on getting insurance approval, and some offer additional vitamins and supplements at no charge for the patients. Most require patients to register for copay cards. However, the Pertzy's copay card is universal and doesn't require the patient to enroll in anything. Inhaled medications like Pulmozyme, Caistin, and Toby Podhaler also have copay cards and patient assistance programs. These programs can make the difference between a family being able to start or continue therapies versus going without. Grant funds are also available to reduce medications. In addition to the manufacturer programs, nonprofit grants help reduce costs. Organizations like HealthWell Foundation provide treatment and supplement grants for CF. The treatment grant offers $15,000 to cover specific CF-related prescription drug copays. They also offer, for Medicare Part B patients, insurance premium coverage. There is a household income limit of 500% of the federal poverty line that is adjusted with household size and high cost of living and income. The Patient Advocate Foundation grant has a max award amount of $5,000. It can be used for copays, co-insurances, and deductibles. Additionally, they also allow it to be used for office visits and administration charges related to treatment. Lastly, the award benefit can be used for medical insurance premiums. This grant eligibility requirements are also the 500% or less of the federal poverty guideline. Patients must reside and receive their treatment in the United States. There's also the Assistance Fund that offers copay relief for U.S. citizens and permanent residents who have prescription coverage for their medications. They also have to meet the financial eligibility determined with household income and size. This copay program usually reduces the copays down to $10 for the patients. The list of covered medications is a little more limited with this fund, and they often have a wait list. The important thing to remember about the Assistance Fund is the wait list applicants expire at the end of every calendar year. So if they're still seeking that assistance and they haven't been allowed to enroll, you do have to re-enroll them at the beginning of the next year. And with all of these grant funds, they are limited and very competitive. So helping families apply quickly is key. It's also something to consider if the patient has another diagnosis like asthma. Sometimes there's asthma grants available that can help you maximize the benefits of their grants. And it's important to pay attention to how you bill them. Make sure the right fund or right grant is billed if you're doing like an asthma and a CF grant. Specialty pharmacy coordination. Specialty pharmacies are essential for CF care. Our goal is to fill as many prescriptions as possible through one specialty pharmacy to simplify the process. When patients need outside pharmacies, we work with dedicated contacts there. We also proactively communicate updates so prescriptions don't get delayed. This coordination prevents gaps in therapy and reduces stress for families. Here is a message from a person with CF. I'd like to share, this is a real example from a person with CF. They've learned their HealthWell grant was being billed incorrectly, which meant funds were being used up prematurely. Once corrected, they recovered over $13,000 of grant funds that could be used towards other expenses. This story highlights how careful monitoring and advocacy can make a tangible difference in someone's life. Finally, I want to highlight CF Foundation Compass. It's a free confidential resource. Compass helps patients and families understand insurance options, troubleshoot challenges, and connect with financial resources. They also provide guidance on legal rights, disability benefits, and transplant planning. Additionally, patients don't have to fight alone. This is available. There's help available. And then top 5 tips for patients and families. Tips I share with families to help reduce stress around medications. First, ask for early refills. Specialty medications can take several days to ship. So I encourage my families to schedule 5 to 10 days before running out and to use patient assistance programs whenever possible. They can help cover costs or fill gaps if insurance lapses. Third, stay in touch with your CF care team. If something feels off, like a missing delivery, a denied claim, or confusion about a dosing, reach out right away. Fourth, document everything. Even keeping a simple log of who you spoke to can save so much frustration. And finally, don't fight alone. If you're hitting barriers, let your care team help. We're trained to navigate these. Why adherence is hard. Even when access is secured, sticking to a treatment is challenging. Treatment fatigue is real. Side effects can discourage patients. Teens especially may resist treatments because they want to feel normal. Life is busy with school, jobs, meals, appointments. Fitting in hours of treatments isn't easy. Caregivers sometimes feel guilty for missed doses, and patients may question the benefit if results aren't immediately obvious. And on top of all of this, the process of refilling medications can be complicated and expensive and seem expensive. My message to patients and families, you're doing your best and that counts. Why adherence matters. So why do we keep emphasizing adherence? Because it truly makes a difference. Adherence helps prevent lung damage, reduce infections, and keep people out of the hospital. It allows people with CF to thrive longer and work toward their personal goals, whether that's graduating, starting a career, or simply having the energy to enjoy life. Adherence opened these doors. The Quittner study found higher rates of hospitalization and higher healthcare costs in the group with lower medication adherence. The Durham article shows great lung function variability with lower adherence. Great lung function variability can lead to lower lung function over time. Tips to make adherence easier. There are practical ways to make adherence more manageable. Use tech tools like reminder apps or alarms. The CFF has the CF My Way app, and tools like MediSafe can be very helpful. Pair medications with daily habits. For example, nebulizer time can coincide with screen time, or morning meds can be taken with your favorite breakfast. Pharmacy apps can simplify refills, and adding auto refills to non-specialty meds can save time. Some families use visual calendars, posting them on the refrigerator or a bedroom wall. The key message here is don't aim for perfection, aim for progress. Key resources, I want to highlight a few. Your CF pharmacy team, we're your first line of defense, so never hesitate to reach out. CF Foundation Compass, their staff are experts in navigating insurance and financial barriers. Manufacturer programs like HealthWell can help with the cost. The Assistance Fund and Patient Advocate Foundation are also crucial resources. These are lifelines for families knowing where they can turn, and it can make all the difference. Final message, behind every medication is a patient or caregiver working hard to make it happen. You don't have to do it alone. Your CF care team and these resources exist to help. Please remember, it's okay to ask for help. We are here for you, and we are not alone in this fight. Before I close, I want to point out an additional resource here at the NACFC. Please consider visiting poster 470, which looks at the financial and administrative impacts on people with CF, as well as the role of the pharmacists and pharmacy technicians when there are changes in the pharmaceutical distribution networks. This work was done in collaboration with several CF centers, including UC San Diego, UNC Health, University of Utah, Iowa Healthcare, Indiana University Health, and Riley Children's Health. It's a great way to dive deeper into the system-wide challenges that impact access and affordability. What questions do you guys have? Anybody? Any online?
Since the question was asked earlier and you actually participate in the CF clinic, can you talk about what you do when you go to clinic?
So when I go to clinic, I first clinic prep to see who's coming in. Have they been difficult to reach at our internal pharmacy, specialty pharmacy? If they've not been answering their phone calls to schedule medications, I will go in their room at their office visit and schedule their refills for delivery. That way I've got them cornered in that room and they can't call me back later. I need to know what medicines you have and how am I going to get these to you and what day. I also make sure that they are getting their eye exams if they're on modulators. I'll call the offices and get those reports faxed to us. I ask them if they're having any issues with copays, any billing issues at external pharmacies that I can help get resolved, and just anything else that comes up. What else? Yeah.
You had mentioned HealthWell grants. I think we just learned that their funding is kind of dried up for the moment. Do you have any insight?
Yes.
To how that goes? They have to grow.
So it is closed currently. This did happen the last year around this time too. It was closed for about a month last year for the treatment grant. It did open back up. I know previously the amount had been $20,000, but they lowered it to $15,000 per award amount. And usually it's all based on donors. So as soon as they get more donations, then they open those back up.
Okay, so it's not based on the federal government or the federal government?
To my knowledge, it's just donations. The vitamin and supplement grant has been closed most of the year. I do know that that has been very challenging. So it's important to lean into those enzyme programs that offer the free vitamins and supplements.
Just piggybacking off that question, do you know how, when funds become available, how do you track that? Is there a...
You can sign up for email alerts when the funds open and close. For my patients who are needing them, we make a follow-up task that we track, and I know just what day those fall on. So when I get email notification that those grant funds open, I stop everything I'm doing, whether I'm in clinic or not, and enroll everybody on my list to help get those as quickly as possible for everyone in need.
I have a question.
Yeah.
So you talked about you had the patient that after reviewing his grant, you saved him $13,000. So how do you monitor those? Like, what's the best one?
So with this patient, it was a specialty pharmacy that got access to a new medication. And so I was able to look at his copay assistance portal and also his HealthWell grant portal and see on those dates what was being billed and for how much. And I was able to piece together that they were billing primary insurance and then a grant instead of billing his copay card and then the grant as the next payment.
Is that something that you monitor like regularly or only when patients reach out that there's an issue?
I tend to, while I'm clinic prepping, look at grants and how much has been utilized to see and kind of prepare myself if they come in and say, I don't know how I'm going to pay for my medication. I've used all my grant fund. So I kind of proactively do that on specific patients that use a lot of their grant fundings and copay cards.
Do you know how long you have to like that bill if you do find something like that is happening? Will they reimburse and what's the window?
I had recently had an external pharmacy backdate for 6 months to that grant fund. I don't know. I'm sure the grant fund has more specific criteria, but I think it is a pretty big window. What else? Yeah.
Sorry, can you ask who are the wonderful SPs?
I am. Our center is adult and peds. We have 3 full-time pharmacists and 2 full-time technicians in clinic.
And so do you typically split your work with the other technician?
Yeah.
Or is it kind of like split between like when you are off?
No, we share everything. My coworker will be in clinic. We have the option for clinics 4 days a week between the adult and the peds clinic. So my coworker will be in clinic 2 days a week, and then I will be in clinic 2 days a week, but we just go back and forth. When we're remote, we have more challenging tasks to complete versus when you're inpatient or in clinic in front of the patient.
Because I know those phone calls to the insurance company can take coverage all day.
Yeah. So the technician working remotely or not in clinic that day primarily does the phone calls.
In terms of, I guess when you started your program for the technicians, did you guys depend on the CFF grant to start it?
Yes. Yeah.
And how many do you have, how many technicians do you have in your center?
Rebecca, do you want to help me with this?
On the pediatric side, we have over 400, and then on the adult side, it's over 3.
Yeah.
I'm saying 300, yeah.
Yeah. Any other questions?
One more right over here on the left.
So with the HealthWell program, there's like a master account you can have to be able to track different patient accounts and know when somebody's coming up for re-enrollment. Is there something that exists for the other patient assistance programs like the Creum Care Forward? There is.
There is. Usually the Creon Care Forward, you can log in as a provider and enroll all of them. The patient also gets a personal account that they can go in and order their supplements and vitamins through. Some of our patients give us access if they're having issues downloading their copay card or getting that processing information, and then we can go in and help them get that and coordinate that. I know the Pulmozyme program has a portal for providers also.
Great question. Thank you.
Okay. Up next, we have Greg Guay. He is a pharmacist at Nebraska Medicine Adult Cystic Fibrosis Center and Specialty Pharmacy. This is his third time attending NACFC after joining the Nebraska Medicine CF team in April of 2023. Born in China, he obtained his bachelor's and master's degree at Xicheng University before crossing the Pacific Ocean to attend pharmacy school at the University of Nebraska Medical Center. Outside of work, he is obsessed with food, travel, and soccer. Welcome, Greg.
Thank you so much for the introduction, Kelly. So my talk is about the chronic medications in CF. And let's take a sip of coffee and dive in. And I have nothing to disclose. So we'll do overview on the common chronic medications in CF, probably spend a little bit more time on the inhaled antibiotics and the CFTR modulators. And if we have some time left, I want to talk about the challenges in the medication treatment and see how we can maximize them. So as we all know, CF involves multiple organs and systems, so it is common our patients take medications targeting different systems. So our first stop will be in the lungs. So in the lungs, the abnormal CFTR protein can cause reduced airway surface liquid hydration and cause thickened mucus. And so we use these medications to help patients to clear mucus and breathe better. The first group of medications are bronchodilators. They're the beta agonists. They're often used before or with other airway clearance therapies to open up airways and enhance drug delivery. And the second one is a nebulized hypertonic saline, and they will use osmotic gradients to draw water into the airway to rehydrate the sputum and improves the clearance. And it's worth mentioning the brand Palmacell is balanced with sodium bicarbonate. So if the patient complains intolerable to the generic hypertonic saline, you may change to the brand Palmacell. And the third one is Dornase alpha, or what I call the lung Drano, because it's an enzyme that cleaves the DNA in the sputum and reducing the viscosity, just like the Drano declogs hair in your drain. And it's important to educate the patient about the proper order of those treatments. First, you want to use a bronchodilator, like we mentioned in the previous slides, knock, knock, open the door, and use hypertonic saline to clean the room, and Dornase alpha to remove the stains before you send in the killer inhaled antibiotics, which we're going to talk next. But first, who are the criminals? And these are the data from the 2023 patient registry report. And it shows you the prevalence of the respiratory microorganism by age and each year. And Pseudomonas aeruginosa is our main target because it's related with rapid decline in lung function and decreased survival. 2 inhaled antibiotics approved by the FDA, tobramycin and aztreonam. And at our center, we typically use tobramycin first because it's approved first, and we've been using that for a few years before aztreonam got approved. But a few other things to consider. First is the ease of use. Tobramycin is usually twice a day, and aztreonam is 3 times a day. Aztreonam also requires reconstitution and use with the Altera system. And of all 3 medications, the dry powder inhaler, the tobramycin dry powder inhaler can store it in room temperature and is much portable. A lot of people like it. And the second thing is access and cost. Both medications are specialty medications, but aztreonam is a limited distribution drug, so it's a little harder to get. And of course, if the patient experiences side effects on one drug, you can switch to a different one. But what if neither of the drugs are of choice? We use some now FDA-approved antibiotics. We basically use the IV form and just nebulize those medications. So here are the list of some antibiotics we use at our center. But how do we pick from those medications? So sensitivity report is always good, is always helpful. And also look at other bacteria growing in the sputum culture can also help you to choose, just kill two birds with one stone. So here's a summary of the inhaled antibiotics. And I just want to point out a few things. For tobramycin nebulized solution, we should use peri-LC plus nebulizer. And it is contraindicated in pregnancy. So if you have patient get pregnant, so stop the tobramycin. As Shunam already mentioned, the administration in the previous slide. But if the patient complains, I cannot do the second dose in the middle of the day, they can do that at home, then wait for 4 hours to do the third dose. And for the non-FDA approved ones, they require home reconstitution with additional supplies. And pharmacy access and insurance coverage can be an issue. For example, Colistin, the cash price is over $1,500 at our pharmacy. And of course, the pharmacokinetics and penetration in the lungs may be a little questionable because it's non-FDA approved and don't have too much good data on those. And I made a tip sheet for our residents and nurses to order those non-specialty, non-FDA approved antibiotics. So the mucus plug-in and the bacterial infection can cause problem more than themselves. So on the right, the graph shows you the lung damage in CF patients. So you have the mucus, thickened mucus, creates a perfect breeding nest for the bacteria and cause persistent infection, which will leads to chronic inflammation and make the airway wall thickened, or what we call bronchiectasis. And that makes CF patient prone to pulmonary exacerbation, which in turn can cause more persistent infection. So we want to break the vicious cycle, right? And we use azithromycin here by inserting anti-inflammatory and biofilm activity against Pseudomonas aeruginosa. So study shows azithromycin is related with the reduced FEV1 decline and exacerbation rate. However, azithromycin can increase the non-tuberculosis mycobacteria infection. So definitely check the sputum culture before initiation. And we typically hold azithromycin if a patient needs to take fluoroquinolones for acute illness because both medication can contribute to QT prolongation. The other anti-inflammatory therapy is high-dose ibuprofen. The clinical data is shows the benefit in young adults or pediatric patients, with a slower FEV1 decline and improved long-term survival. There's only 1% of adults are prescribed in 2023 patient registry report. It needs to have a 3-hour pharmacokinetic study to decide on the dose, and you want to monitor for the side effects, CBC, blood chemistry, and a urine analysis. So while I was in pharmacy school, which seems a long time ago, CF was still mostly inpatient disease, and we actually learned that in infectious disease section of pharmacotherapy. So CFTR modulators are the game changer. On the graph, we have two pills. The first one is the potentiator. It helps the CFTR protein already on the cell surface to open longer and better. And the second pill is called corrector. It helps with the misfolding of the protein and transport them to the cell surface. The very first CFTR modulators was approved in 2012. It's called ivacaftor, which only serves as a potentiator. In 2015, there's first corrector lumacaftor was added to ivacaftor to target homozygous del508 mutations. In 2018, we have new medication, tizacaftor, ivacaftor, which showed better tolerability compared to Lumaiva. In 2019, everyone knows, right? ETI was introduced. It is the first 3-drug combination with the additional secondary corrector. And last year, the very first once-daily dosing modulator, vanzacaftor, tizacaftor, tificaftor, was approved. And ever since the introduction of ETI, it has quickly become dominant. And this graph shows you the use of CFTR modulators since 2019. And you can see in just under 6 years, the use of ETI jumped from 20% to 76%. And this gives you a better look of the usage in 2024. So one of the reasons is probably the eligibility. So this is the percentage of genotypes based on 2023 patient registry report. And you have over 40% of the Delta 508 homozygous and heterozygous and the other genotypes. And ETI, you can use that in the yellow part, you can use that in the blue part, and you can use that in some of the responsive mutations, which is in the green part. And it worked so well, right? So this is a PFT trend of two of our patients. And the blue dots means the hospitalization and antibiotic use. And you can see it make a huge difference. The number of pregnancies in women has bumped since 2019. It is also changing the way we practice, right? We're rethinking, do we still need the treatments we have been doing for so many years? Like the Simplify study, do we still need to use both hypertonic saline and Dornase alpha? And the HERO2 trial, look at the lung function change in patients who made treatment change since ETI initiation. I'm sure you will hear more about it in the next few days. So as pharmacists, it is our responsibility to make sure patients get the most out of those medications. They should be administered with high fat containing food because all the ingredients has poor solubility in aqueous environment. The drug-drug interaction is worth noticing because they're all CYP3A4 substrates, so avoid grapefruit juice, as well as watch other drug-drug interaction. ETI has blue pills and orange pills, so definitely make sure education about missed dose management is a little special. We want to monitor the liver function, pulmonary function, and for little kids, their eye exam. Adverse reactions has posed a lot of challenges for our patients taking those medications. This is a graph shows the BMI of one of our patients. Before the ETI initiation, the BMI was in the 40s. Then after ETI, it crossed up to the 60s. Mental health problem has raising more and more concerns. Some patients have to stop taking the ETI because the mental health challenge, and they experience like brain fog, or in their words, I just don't feel like myself. So how can we manage those side effects? I think the first step is baseline screening and close monitor after you initiate the therapy. For example, your liver function test and PHQ-9 for mental health problem. And if the patient develops side effects, let's take a break and re-challenge maybe in later with a reduced dose, even though a lot of times our providers like, yeah, just do whatever you want. So we don't have good guidance on how to reduce the dose properly. And we can switch to modulators, especially now we have one more options available. And of course, if the patient is still not able to tolerate despite everything you tried, then the shared decision, like maybe we can discontinue the treatment. Okay, let's switch gear a little bit, talk about gastrointestinal and nutrition support. So CF often causes exocrine pancreatic insufficiency, or EPI. So what do we do if patient is lacking pancreatic enzyme? We give them extra enzyme, right, to help them better digest and absorb nutrients. So PERT therapy uses extracts of porcine pancreas containing lipase, amylase, and protease, which helps digestion of fat, carbs, and proteins. The counseling on the administration is important. They help with digestion, so make sure to take with food. If the patient wants to open up the capsule, especially kids, they can mix with applesauce or non-alkaline food because they protect the enteric coating. Same reason, do not crush or chew the beads. Once the enzyme reaches the duodenum, the low pH may inactivate the enzyme, so use of acid suppressors can be helpful. Adverse reactions are usually related to under or overdosing, and a few more things to think about. Brands are not interchangeable, and patients may don't want to take the PERT therapy because the capsule contains gelatin, and the active ingredients we mentioned earlier are extracts of porcine pancreas. They're also a big contributor to pill burden, so consider using higher strengths if possible. Patients may also need supplemental minerals and fat-soluble vitamin supplements, but after CFTR modulator therapy, there may be some improvement in the levels, so definitely check and adjust if needed. A lot of patients are really troubled by constipation or distal intestinal obstruction syndrome. So we'll see they take medications like polyethylene glycol or Senna or lactulose. Ursodol can be used for CF-related liver disease. However, study shows it may improve the liver test, but there's no evidence improving the clinical outcomes, like reversing or maintaining the liver function. What about endocrine? There's about 24 patients with CF affected by CF-related diabetes. Insulin therapy is the only recommended and approved therapy for CFRD. It is because CFRD is primarily the defect of insulin production due to the fibrosis and fatty replacement in the pancreas. And actually, that's how the name cystic fibrosis come from. The obese and overweight is becoming more and more common. So we're seeing some patients may take medications to manage the weight, for example, GLP-1 agonists and metformin. And also because the more absorption of the nutrients, a patient may experience bone health issue, so they're taking medications for that. Mental health can be a challenge for some CF patients as well. So we'll see they can take antidepressants and sleep medications. And in the era of post-ETI, the number of lung transplant is dropped a lot. But for patient post-transplant, they may take medications like immunosuppressants. So everybody still with me? It's a little overwhelming, right? So if you feel like it's overwhelming, think about the patients who have to take that every day in their life. And I think Julie, Lisa made a really good comments and discussions how we can approach from the pharmaceutical care standpoint. So I'm not going to go into too much details, but I think it's worth re-emphasize the challenges in their medication treatments. It sucked time, right? This is just a list of the medications our patient take, one for my patient take. And there's a lot of things to keep in mind, like the orders of medication, how to take them, how to store them. And it's just simply a lot of things to take. And even if you have a perfect patient does everything they should, they may still have side effects. They may have problem with the insurance, with the pharmacies, and all of that can lead to a lot of stress. So how can we help? So I try to wrap up my talks with just a little fun way. I like cooking, as Kelly mentioned. So I think it's just like cooking a steak. So I think laying the foundation by building trust and understanding is like marinate your steak with salt and pepper before you cook. And each cut and size should be cooked differently, so make sure it meet individual needs. Utilize tools, technology, and the support system, just like Julie mentioned earlier. Like you should use iron cast pans and stainless steel pans for cooking. And first step of cooking is secure a good crust and sear on the steak. Just like the first step of the medication treatment is getting the medication. And try not to overcook or burn the steak, so monitor for side effects and optimize your therapy. And there will be a lot of smoke, so try to get rid of the treatment and pill burden if you can. And lastly, encourage the long-term engagement of the patients. Enforce why you're taking those meds, link the outcomes to the treatments, and encourage them if they make some progress. It's like the thyme and rosemary. You don't need a lot, but it will make a difference. And voila, you're going to be the Gordon Ramsay of the chronic medication treatments. All right, this is my contact, and I'm ready for some question and roasting. Yeah, thank you.
All right, do we have any questions out there for Greg? All right. Go for it.
Yeah,
also in our specialty pharmacy within the hospital. I'm seeing a lot of problems with adherence with Pulmozyme, just because it's patients that are on modulators feel like they just don't need it. And our providers are kind of like, I'm not gonna tell you not to use it, but I'm also gonna encourage you to keep using it, but we're just kind of at that stage where we don't know really what guidelines to give them. And then also, the specialty pharmacy side, we're having, we have to document its adherence because it's kind of that fuzzy area. So is that something that you experienced, and how do you handle that?
Yeah, great question. So the question is about how do we handle the slipping adherence for medication, for example, like Pulmozyme. So I think that's just related to, post ETI, post, highly effective modulator therapy. And patient, if they feel great, then yeah, I think it's a common, right? It's common human feeling. They don't want to do the treatments that cost a lot of time, especially the nebulized treatment. So again, I think it's important to link the outcomes to the medication treatment. And also don't think your job is making sure a patient take every single medication. I mean, it's important, but ultimately, we want to make sure they have good lung function, they live a good life like other people. So yeah, if, your lung function is great, yeah, I think like the simplified study shows, maybe you don't need to do those treatments. But bottom line is we want to make sure your lung function is good. So you can take a step back. So yeah, if you don't want to take it, cool. But let's check your lung function after 3 months. If it's still doing good, you're doing a great job, like exercise, it probably makes sense they don't take them, right? But if they're slipping in their lung function or they don't feel great, they have more exacerbation, then that would be the time like, hey, buddy, let's try to, do a little better with your airway clearance. I mean, I think everybody can share the same feeling, right? It's the problem. I think that's just my approach. Yeah.
And what are some of the classes of medications that you might see less adherence to since
Yeah. So the question is, what other medication classes has the biggest lapse of adherence after ETI? So airway clearance, of course, a lot of people don't want to do them because they cost a lot of time. And if they're traveling, it's a lot of things to carry, right? With machines and stuff. And the other things are vitamins, because patients don't feel the difference immediately if they don't take vitamins. So I think and again, linked outcomes to the treatments, like, hey, let's look at your levels, right? If levels are doing good, then we probably can taper down or even discontinue the vitamins. Yeah, those are two first things come to my mind. And I think patients usually do a pretty good job taking their enzyme because they feel different if they don't take enzyme usually. And GI stuff, it kind of weirdly, most patients don't feel very different after ETI. And maybe have 1 or 2 patients feels it's beneficial. So they're usually pretty good on those things. Yeah. Any other questions? Yeah. Hi.
On your modulator slide, as far as the age for the electric, it indicated greater or equal to 2 years of age. Do you use that in your clinic? Because for us, in our clinic, we use it for 6 years of age.
Sure. So the question is about age approved for the new modulator Venza. So we're actually at adults center, so I don't have a personal experience, but maybe, Mariella.
I can answer that. It is approved 6 and up, so we're only using it for 6 years and up. I know, at least in my center in Atlanta, we were part of the study for the 2 to 6, but we're still waiting on those results. So 6 and up for Alyftrek.
Thank you.
Mm-hmm.
Yes.
You had mentioned some of the mental health concerns surrounding the UTI. We've had some success having the dose or reducing the dose. Is that something that's becoming practice?
Yeah, so the question is about how do we manage the mental health issue with the modulators. So we did try, flipping the dosing, especially for ETI, the blue pill and the orange pill, and reduce the dose. Say, for example, like just take the orange pill, skip the blue pill, or just take one pill. And honestly, I don't think it makes a big difference. The patient still kind of not be able to tolerate. Yeah, it's a very tough problem. Even, with the new modulator come to the market, the patient still doesn't want to take because they're experienced with the ETI. So yeah, I don't think that reducing dose is helpful from my personal experience. Yeah.
We've had some success reducing the dose. I think it just depends on the person and the co-production of what they are getting out of the modulator, right? Because it's risk benefit. Like we have some people that are terrified to come off of it, even though they're having lots of side effects because their lung function is very low. We have some people that are non-adherent at baseline, and so when they start to have a side effect, they just stop it on their own, and we find out later. The CF Learning Network is actually doing a project right now. So if there's others like in CFLN, we're in the middle of a project and looking at responding to modulator side effects. So we'll know more in March. Yeah. So I think there'll be more data. But we have probably about 30 adults and maybe 12 kids on adjusted doses that have been able to tolerate the lower dose. So for what that's worth, it's almost like, I think of it as like a salvage regimen. So we have had some success. I'm not saying it always works, if that helps.
Yeah, and I would concur with that in the pediatric side. I see pediatric patients, and we've had success in reducing doses. There's been times where we actually done a sweat test afterwards to see if they're still effective at pretty low doses. And a lot of times we're still seeing good response on the sweat test, although they're taking very low doses.
Thank you.
I would also agree with everything that's been said up here too. And as long as you're tracking the PFTs, I think a reduced dose is completely appropriate as well.
There was a question in the back. Did you?
Yeah, so the question is about how do we initiate the mental health medications in our CF patient. So we typically don't initiate therapy from our CF team. I think usually we would refer to the primary care doctor or a psychiatrist. We do have a psychologist in our team. So I think those are probably more appropriate person if you want to start the antidepressant, just because, it can be CF related and can also include other, social reason or other reasons. So it may be more appropriate to start with the primary care doctor or psychiatrist. Yeah.
Yes.
So, actually, I'm a psychiatrist that works at a CF care center, and I will say I haven't seen anybody that I thought was having mental health issues from the ETI. What's interesting is I get to learn a lot of patients that don't take it, they're not adherent to the modulator for various reasons. So I was wondering if you guys have a lot of patients that do that, or even patients that don't take the modulator, and they're all sort of different reasons.
Yeah. So the question is about what are the reasons of varied adherence of the modulators. So typically our patients are taking their modulators pretty well. I think that's probably the only medication they take on time. But we do have some patient who does not take modulators very good. I think some possible reasons is cost access, right? And you can have problems getting the medication. And second is maybe they feel great, like they're young, they don't see the long term, the road downward. So they're like, yeah, I'm invincible. I'm in my 20s. I don't need to take this medication. I feel great. And also the side effects, right? We have patients do not want to take the modulator, or they only take that less than prescribed because they gain weight or have other side effects. So I think those are the reasons I can think about. Mm-hmm. All great questions. Thank you so much. guys. Any other questions? Okay, perfect. Thank you, sir. Thank you.
All right, thank you. And so we're going to introduce our final speaker. So Mariella Duvall, she's a clinical pharmacy specialist. Mariella completed her pediatric specialty pharmacist at Children's Healthcare of Atlanta. She specializes in caring for children living with cystic fibrosis, both in a hospital as well as a clinic setting. Originally from Nicaragua, she moved from the U.S. to the U.S. as a teenager and comes from a family of pharmacists. She earned her Doctor of Pharmacy degree from the University of Florida and completed her pediatric residency at the University of Tennessee in Memphis. Mariella teaches pharmacy students and residents and serves as an adjunct professor at Mercer University and the University of Georgia. Outside of pharmacy, she's also a newborn and maternity photographer as well as an avid traveler. So thank you. Welcome her out.
Thank you, Kyle. So we're going to switch to talking about acute care in cystic fibrosis. So it actually warms my heart that in a presentation like this, and there's 4 of us speaking, I'm the only one talking about the care of CF in the hospital. And we spent all this time talking about outpatient and CF. I've been doing CF in the inpatient and outpatient setting for about 20 years now. And I know you're going to hear this a lot. The face of CF has completely changed in the last decade and especially in the last 5 years. I have no relationships to disclose related to this presentation. So my objectives for the next 20 minutes or so is to define pulmonary exacerbation, recognize what are the acute presentations in CF, what happens with everything that we have talked about up to now does not work and gets the patient sick. How can we optimize antimicrobial therapy using pharmacokinetics parameters that are specific for CF, and then identify the pharmacist's roles that they play in the hospital. So what is a pulmonary exacerbation? There's no universal accepted definition, and probably because there's not a standard way that patients present with an exacerbation. There's a constellation of symptoms that are GI and respiratory, but and those include increased cough and mucus production, which are more than their regular baseline. We get shortness of breath, fatigue, decreased appetite that leads to weight loss, and decline in lung function. And what is this decline? There's, again, not a universal accepted number. Some people would say 10%, but a clinician may admit with a 5% decline, and that same clinician could admit with a decline of 15%. So it needs to be individualized to each patient and to each exacerbation and how they look. And why is it important to recognize the exacerbations and treat them? We know they're predictors of future events. Once the patient gets an exacerbation that requires a hospital stay, most likely they're going to have another one. And we don't always get them back to their baseline lung function. So every time we might be losing a little bit of lung function. So it's important to be aggressive and treat them. So we talked a lot about CF in the outpatient setting, and we have seen a huge movement. Greg talked about in pharmacy school, he learned about CF being more of an inpatient disease. That's obviously how I learned it too, and how I actually manage most of my patients. But we've seen a huge decrease in the number of patients that have been hospitalized or require an IV antibiotics just in the last 5 years. So if you look at the patient registry from 2019 to 2024, 40% of people with CF had at least one pulmonary exacerbation that required IV antibiotics. Fast forward just 5 years to 2024, and that number is down to 15%. So significantly decreased. And the same we see in pediatrics, from 21% in 2019 down to 9% in 2024. So we have transitioned from having lots and lots of resources in the hospital to now moving all those resources to the clinic. So what causes a pulmonary exacerbation? We have the classical causes of being bacterial infections, but also a lot of exacerbations can present as a viral infection, especially in pediatrics that are a major trigger of a pulmonary exacerbation. And up to 40% of adults can also develop an exacerbation due to viral infections. They can also be environmental factors, so the start of school where kids are sharing a lot of germs, or the start of respiratory season, or if there are lots of stressors like losing jobs or changing jobs or losing insurance. Poor adherence, so the patient is not taking their medications, not doing their treatments, or barriers to therapy, like we talked about, if they lose insurance or they're not having, or the insurance is no longer covering their medication, and there's not a wonderful Julie in their clinic that's taking care of them. So these are the common bacterial pathogens that cause a pulmonary exacerbation. And Greg already talked about that and showed you that nice graph of where you see them based on age. Pseudomonas has always gone with CF. You think CF, you think Pseudomonas. But we also see a lot of staph, MRSA and MSSA. And then some of the multi-resistant organisms such as Stenotrophomonas, Achromobacter, non-tuberculous, and Cepacia. But what I really wanted to point out is that we're seeing a decreased number of these pathogens since the start of the highly effective modulators. Again, looking at the patient registry data, just comparing the numbers from 2015 to 2024, Pseudomonas, 47.5% of people with CF were infected with Pseudomonas in 2015. That number is down to 23% in 2024. So a huge decrease. MRSA, the number has also been cut in half from 26% to 13%. And if you look at Stenotrophomonas, Achromobacter, and Cepacia, those numbers are now very, very low. So we're seeing a lot less patients that are being infected with these pathogens. The non-tuberculous mycobacteria, which I find it very interesting, has actually stayed the same. So a patient comes into the hospital. We as pharmacists can play a big role in choosing the best antibiotic for that patient, and we can be good antibiotic stewards. Again, before patient came in, I always immediately thought Pseudomonas and I needed to cover for Pseudomonas. That may or may not be the case anymore. So it really needs to be based on center data. It's the percent of your patients that are infected with Pseudomonas, and then be more specific to that patient. What does that patient grow, and what does it need? And then the other question you need to ask is, do we single cover for that Pseudomonas, or we double cover? And hopefully we'll have answers to that question within a year. So then in choosing your empiric IV antibiotics, you want to look at, again, that specific patient and look at their most recent cultures. Some centers will look at their cultures in the last year or 2 years or 3 years, and then cover whatever are those organisms that they have grown in their sputum cultures. If there's no previous culture results, which we actually see sometimes in our pediatric patients, then we would use empiric antibiotics for that particular patient, for that particular age, and for that particular presentation. So our priorities for treatment is to simplify the treatment burden in the hospital, use the most effective antibiotic that will cause the least side effect. So we know that in cystic fibrosis, we see a lot of pharmacokinetic changes. And those changes affect how we dose it and how we give it. When we look at the pharmacokinetics, actually a lot of them are on beta-lactams and aminoglycosides. And they have also been done before the introduction of the very highly effective modulators. They have shown minimal difference in absorption, but we see an increase in volume distribution and also an increase in renal clearance. We know that CFTR receptors are highly expressed in the kidneys. So if those are not working, we're going to see an increase in glomerular filtration. So overall, we end up with much higher doses and or more frequent doses. Talking about the highly effective modulators and the impact it's going to have on pharmacokinetics, we don't know that yet. There was a study published earlier this year by Dr. Hardwood out of Australia, and they looked at tobramycin pharmacokinetics in pediatrics, and about 40% of their patients were on modulators. So they separated it and looked at patients on modulator versus patients not on modulator, and they did not see a difference in the pharmacokinetic and the pharmacokinetics of tobramycin in pediatric patients. About 15 to 20% of their patients were on highly effective modulators, so I don't know. I guess we need to learn more about the impact that it'll have on our dosing. But for now, we just have to use the information that we have, so go with higher doses and more frequent doses. There's been a number of our colleagues, pharmacy colleagues, that have published some beautiful studies on the correct doses for beta-lactams and aminoglycosides in the literature and what we should be using. If you look at beta-lactams, which are one of the main medications that we use for the treatment of Pseudomonas, the recommended doses are much higher than what we'd use in the regular patients. Do we do intermittent infusion, extended infusion, and continuous infusion? There is probably more data needed for that, but most people would recommend extended or continuous infusion if the patient has higher MIC, because you do get better outcomes since they work better as being above the MIC level. If you need to treat MRSA, because that's what the patient grows, in my center, we usually use vancomycin or linezolid. There's quite a bit of studies recommending vancomycin either AUC or trough level. So you can look at those literature, but those are the main medications that we use in the hospital. If you're outpatient or the patient can take oral medication, clindamycin or Bactrim or minocycline, doxycycline also work well. Again, looking at your susceptibility data and picking the best antibiotic for those patients. And then if the patient's only growing MSSA, we can actually narrow down the therapy and just pick an antibiotic that will just be specific to treat MSSA, such as cefazolin or oxacillin or nafcillin. I prefer oxacillin just because of decreased renal toxicity with it and less hypokalemia than with nafcillin, but it would depend on your formulary. Now, if I have to treat MSSA, but I also need to treat Pseudomonas, my go-to antibiotic is either piperacillin tazo or cefepime, and then meropenem as my last choice. Just that way I can double cover the Pseudomonas and also cover the MSSA. If the patient grows Achromobacter, we have more limited antibiotics that we can use, and these are the typical ones that will show up in your susceptibility patterns. There's really no studies to show that you need to single or double cover this organism. But if you're going to double cover, make sure you're picking antibiotics with two different mechanisms of action. In my center, the way the susceptibilities show, it's usually piptazo or meropenem, the ones that I use the most. And then on the outpatient, Bactrim or minocycline, doxycycline. For stenotrophomonas, there is not any specific literature that says that this is pathogenic. So some people choose to treat it, some people don't. They tend to be more shown of more progressive disease. I tend to treat it if the patient is sick. We have very limited number of antibiotics to treat stenotrophomonas, with trimethoprim sulfa being the most common one, and levofloxacin, minocycline, and doxy are also recommended. So if we're going to use an aminoglycoside, the one we're going to use is tobramycin, and it's recommended to use it as extended interval. We know they're concentration-dependent killers, and the efficacy correlates with Cmax. So your higher the concentration, the more killing you're going to see. We also know that aminoglycosides exhibit post-antibiotic effect. So they continue to work once you fall below the MIC and even once you go undetected. We know from pharmacokinetic studies they have people living with CF have increased volume distribution as well as increase in renal clearance. So given a much higher dose and letting it come down makes sense. And the studies have shown that when comparing it with traditional dosing, we see an improvement in lung function. We see lower accumulation in the renal tubular and therefore less nephrotoxicity. And of course, less frequent administration, which then is less work for the nurses and less work for pharmacy. And it's recommended by the CF guidelines, pulmonary exacerbation. So the dose for tobramycin lies somewhere between 7.5 to 15 milligrams per kilo. In pediatrics, we start at 10 milligrams per kilo. It's just you'll never get anywhere with 7.5. And then if the child is 5 years or younger, then I usually start at 12 milligrams per kilo. And then you want to do 2 levels, at least 1 half-life apart. So I do 2 and 6 hour levels. Some centers I know do 2 and 8 hour levels. I find that in pediatrics, if I do an 8 hour levels, many times that level is undetected and I need a value to work with. And then what I'm looking at is a peak of 20 to 30. Some people would say 20 to 40, a trough less than 1, an AUC of 80 to 120 or 125. And then following up, you want to do either trough level every 5 to 7 days, or I trend the 6 hour level on a weekly basis. So in an effort to standardize the treatment of pulmonary exacerbation, the CF Foundation has done a couple trials called the STOP trials. And the STOP 2 trial was finalized and has been published. And that looked at duration of therapy. So how long should we be treating these patients in the hospital with IV antibiotics? And then the STOP 360 trial is looking at comparing the efficacy and safety between single and double covering for Pseudomonas. That study is ongoing, but hoping to finalize in 2026. So maybe next year NACFC will have some more data on that. But if we look at the STOP 2 trial, and I'm going to orient you through the graph. So they looked at about 1,000 patients, and then visit 1 was 1 to 3 days from the start of IV antibiotics. So they got their baseline FEV1. Then visit 2, right here, was 7 to 10 days after the start of the IV antibiotics. And that's where the randomization happened. So what they did was they looked at FEV1. So if the patient had an FEV1 greater than 8%, they were called early robust responders. If they had an FEV1 that was less than 8%, then they were non-early robust responder. So once they moved them into groups, then the early robust responders got randomized to 10 days versus 14 days. And then the non-early robust responder got randomized to 14 days versus 21 days. And then they did an FEV1 about 2 weeks after the stop of the IV antibiotics. And they found that there was no difference in the early robust responders. So if they responded early, there was no difference between doing 10 days versus 14 days of IV antibiotics. Now, the ones that took a little bit longer to respond, so the non-robust responders, there was no difference on 14 days versus 21 days. So if you need to treat a full 14 days, going that extra week in the hospital does not make a difference. So the CF Foundation published the pulmonary exacerbation guidelines back in 2009, which now they're 15, 16 years old. But if we looked at that and look at what their recommendations were, they had a very strong recommendation in continuing chronic medications for maintenance of lung health. So all those medications that Greg talked about, we want to continue those in the hospital, except for the inhaled antibiotics. There's insufficient data to continue that in the hospital. A lot of that probably comes from doing inhaled tobramycin as well as IV tobramycin in the hospital and the potential for accumulation and increased risk of nephrotoxicity. I do not continue inhaled antibiotics in the hospital for now, but I know some centers do. And then the number of antibiotics to treat Pseudomonas, they said it was insufficient data. We're going to get an answer for that on the STOP 360 trial, and that includes pediatrics and adult data. And then aminoglycosides dosing, strong recommendation for doing it once daily, so extended interval dosing. In terms of beta-lactam dosing, there was insufficient data back in 2009 whether we should be doing continuous infusion versus intermittent. There's been a lot of studies that have been published since then, and then my recommendation would be if the patient has a MIC that's a little bit higher, closer to the breakdown point, then consider doing continuous or extended interval. The duration of treatment, which I just talked about, again, was answered in the STOP 2 trial. At the time, there was insufficient data, but now it's really 10 days or 14 days. And then there was insufficient evidence also about the use of corticosteroids, and it continues to not really be recommended for the treatment of exacerbations. So we talked a lot about the CFTR modulators and how wonderful they are, and they're the main reason that we've seen a huge decrease of admissions into the hospital. So if they come into the hospital and they are on modulators, we want to continue those. A lot of hospital pharmacies do not have it on their formulary because of cost. So you need to make sure that you counsel the patient to bring those medications with them. So it's part of everything that we tell them of what to bring when they come to the hospital, because we don't have it on our formulary. And then keep in mind that modulators are CYP3A substrates. So if you're adding any new medications to the patients in the hospital, keep in mind of any interactions for any CYP3A inducers or inhibitors. So in summary, acute care in CF requires individualized antimicrobial strategies. We want to use aminoglycosides if we're using it as an extended interval. That improves efficacy and decreased toxicity. And we want to continue all the chronic therapies that they've been on it at home. And then as pharmacists play a big role in choosing the most appropriate antibiotic at the most appropriate dose for that patient to improve care and patient outcome. And last, I want to leave you with this picture of Nora and Henry. And as a photographer, it's been one of the most emotional and important pictures I've taken. You see, their mother was a patient of mine as a child. Their mother was in and out of the hospital, and she was the first patient I had with non-tuberculous mycobacterium, and she spent a lot of years, her teenage years, in the hospital. And to see her now with the use of the highly effective modulators, to see her as a wonderful mother, as a great wife, as a successful career woman, reminds me of why we do what we do. So thank you. Any questions?
Thank you for that. Any questions out there for Mariella? So I know for myself, when I started CF care, this was the hardest topic for me to get it grasped, was inpatient admission. So lots of questions regarding that.
What
what's the rate for readmissions and what do you do or could you do to prevent them?
So we still have, I know we talk about the modulators and being amazing how they've changed the face of CF. We still have a good percentage of patients that either A, do not qualify for the modulators, B, are not taking it because of side effects, C, they're not taking it because of lack of insurance. So there's a lot of reasons for them to not be taking it. Also, although it really helps a lot, they still, for some patients with low FEV1s, they need to continue all their therapies. And they think that all I got to do is pop those pills, 2 in the morning, 1 at night, and I'm done. So there's a lot of it will be adherence. So it's, for me, a lot of the patients that I see are the ones that are not on modulators. I don't know if anyone has different experience. Any other question? Yes.
When you have an admission and you have a patient who is has struggles with access to medication, if they don't bring their modulator, how do you navigate getting it into your hospital?
So the question is, if a patient comes in into the hospital and they are on modulators, but they're lost access to it, how do we navigate that? Actually, I have a 19-year-old in the hospital right now that with that same exact scenario. She lost Medicaid and she doesn't have insurance. So working with case management, trying to get access to it. Unfortunately, we've seen a lot of changes in the programs, even the Vertex program and coverage. So it's difficult. We can't provide it in the hospital if they don't bring it, or if we cannot get access to it. And that's where we need people that specialize in getting the access, and maybe Julie can answer that.
So one thing we're able to do at my facility is utilize our retail pharmacy and our specialty pharmacy to get the modulators sent to the retail pharmacy. Then I will go pick them up and deliver it to the patient's room as a home med. But that's providing they have insurance. It wouldn't help for a patient.
Right. And we don't have a specialty pharmacy. But we've had a specialty pharmacy ship it to us and use it as a home med. But they have to have the insurance, because social work in our hospital sometimes covers a week or 2 weeks, but not $40,000 a month.
To add to that, with her patient in the hospital without insurance, I would go and have them enroll in Vertex GPS and fill out the PAP form and try to work on that as quickly as possible. That way she can schedule, or they can schedule their medication for delivery to maybe their home or a family member who would then be able to bring that in.
Any other questions? I know it's late in the day. And hopefully you guys are not seeing many people with CF in the hospital, because we're managing them all outpatient. All right, thank you.
Thank you very much.